exactly. Okay, and now we move to the next presenter is Azza Fitria Al-Hadifa. Okay, please perform the video presentation.
Morning everyone, thank you for being here. My name is Asa Fitra Hanifa and on behalf of my co-authors Azamira Fadila and Ngakan Putu Krishna Mahayana from the Faculty of Medicine at Udayana University. I'm pleased to present our work. Today, I'll be discussing our systematic review and meta-analysis on the diagnostic performance of artificial intelligence in distinguishing multi-drug resistant from extensively drug-resistant tuberculosis using chest radiography. Tuberculosis remains a major global health threat. The crisis severely exacerbated by the rise of drug-resistant forms, particularly the multi-drug resistant or MDR-TB and the extensively drug-resistant or XDR-TB. While both are dangerous, XDR-TB is associated with significantly worse outcomes. For instance, one study reported that treatment success rates dropped from over 73% from MDR patients to just under 63% for those with XDR-TB. The core challenge, especially in high-burden, resource-limited settings, is the frequent and critical delay in differentiating XDR-TB from MDR-TB. The gold standard culture-based test can take weeks or even months to yield a result. While faster molecular tests exist, their cost and the expertise required limited their availability where they are needed the most. This diagnostic delay often leads to patients receiving inappropriate initial treatment, which can result in treatment failure, the amplification of resistance, and the continuation of transmission of these highly dangerous strains within the community itself. To evaluate a potential solution to this problem, we conducted a systematic review and meta-analysis of diagnostic test accuracy. Our study was designed in accordance with PRISMA guidelines and was prospectively registered in the Prospero database. We performed a comprehensive literature search across PubMed, Scopus, and EBSCO databases. We included studies that specifically used artificial intelligence, machine learning, or deep learning models to classify MDR versus XDR-TB based on chest radiograph images. The quality of its included study was carefully assessed using the QUADAS-2 tool, which is standard for diagnostic test accuracy. Finally, we pulled the diagnostic metrics from the final studies using random effect statistical models. As the flowchart on the right shows, our screening process resulted in 5 studies that met our criteria for the final meta-analysis. So, what did we find? Our analysis revealed that AI models demonstrate a high level of diagnostic performance for this challenging task. The pooled accuracy across the studies was 86%. The models achieve a pooled sensitivity of 82% and a pooled specificity of 90%. As you can see from the summary receiving operating characteristic curve in the left, the overall area under the curve or AUC was 0.93, which indicates excellent overall diagnostic ability. Perhaps most importantly for clinical use, the pooled negative predictive value or NPV was 92%. This suggests that these AI tools are particularly strong at correctly ruling out XDR-TB, providing a high degree of confidence when the test is actually negative. That needs to be boldly stated. These results are promising, but how would this technology be used in practice, right? It is critical to emphasize that AI should complement, not replace, right, the definitive microbiological testing. We propose its most valuable role is as a rapid triage tool to bridge the diagnostic gap. Let's walk through the proposed clinical pathway. The process begins after a patient is confirmed to have a rifampicin-resistant TB, something that we widely have in our puskesmas. At this point, the AI model would analyze the routine chest X-ray, an image that is almost always taken in the secondary line, to generate the risk score for the XDR-TB. This score then guides to the next step. For patients flagged as the high risk, their sputum samples could be prioritized or fast-tracked for limited and slower advanced drug susceptibility tests. In clinically severe cases, this alert might even support a clinician decision to empirically start a broader XDR treatment regimen while waiting for confirmation. Conversely, patients with a low risk score would follow the standard management protocols. This risk-based approach helps optimize the use of limited laboratory resources and, most importantly, accelerates the path to appropriate life-saving therapy for the most critically ill patients. For a balanced perspective, it is essential to acknowledge the quality and limitation of the current body of evidence. Our analysis had several strengths. The Diggs funnel plot was symmetric, indicating no significant publication bias was detected. Furthermore, a leave one out sensitivity analysis confirmed that our results are robust and not overly influenced by any single study. However, we must also recognize the limitation. All included studies were retrospective in design and predominantly use public datasets. This raises concerns about potential selection bias and whether these results will generalize when the new diverse clinical population data is available. There is also risk of model overfitting, where an AI model performs well on its training data but fails to maintain that accuracy when the real data is given. In conclusion, our systematic review and meta-analysis demonstrates that AI analysis of chest radiography shows very promising diagnostic accuracy for distinguishing the XDR from the MDR-TB. It holds very clear potential to serve as a valuable and rapid triage tool in resource-limited settings where definitive testing is oftenly delayed. However, before this technology can be widely adopted, further research is essential. We must move from the retrospective design to prospective, multi-center validation studies to confirm these findings in the real-world clinical workflows. Ultimately, large-scale implementation trials are needed to determine if using an AI triage system is truly improves the key clinical outcomes, like reducing the time to correct therapy, or if it's actually cost-effective. Finally, ensuring these models are validated across diverse patient population is very, very important to promote equity and avoiding algorithmic bias. The findings I've shared today are built upon the important works of many researchers in the field. Thank you very much for your time and attention.
Okay, thank you for your presentation. And now we will move to the Q&A session, and we invite other participants to ask the presenter for the question. Please, everyone, raise your hand. Is there anyone who want to ask?
Maybe I want to ask Azza Fitra for your interesting research and the AI. What do you think about the factors should be considered to ensure the ethical and sustainable development of this technology in high burden TB with the like in Indonesia, developing countries? Maybe Azza, do you mind to share your opinion about the factors should be considered to ensure the sustainable implementation of this technology you propose? Thank you.
Yes, please. Yours, Mr. Azza.
Yeah, thank you for your questions. And this is a very interesting idea because we know that for an AI that wants to be implemented in the system, we really need to consider ethical behind it, right? So we really need to consider this AI to be still under the human under it, right? Because we propose this to be implemented in the pathway as the triage tool. So we cannot replace the human there. So we still emphasize the human in the loop in there. So we as a clinicians, we can say this AI as an input for our decision making, so that in the end of the day we get more insights and make a rational decision to cluster these different patients that have different risks for stratification for our limited settings. Where, for example, culture-based testing is limited, or like something like line probe assay that is faster is also limited. Other than that, we also need to do more research, right? The key outcomes, whether this AI triage tools actually can be better when it is implemented. So we really need to check whether it actually improves the time to correct therapy, improve the patient outcomes, And is it really cost effective when we when we implement this, especially in our settings in Indonesia? So we really need to consider that before implying that in the future. Thank you.